You see a subluxated IOL due to zonulolysis. The surgical time is 25 minutes. I will extract the IOL and implant a irisfixated IOL. I start with insertion of 25 gauge trocars. Next is the insertion of the infusion line. The next step is a limbal peritomy at 12 o'clock. I'm performing a scleral incision in order to reduce the astigmatism. The alternative is a corneal incision, which induces a stronger astigmatism. The next step is to cauterize the bleeding vessels. The next step is important. The incision should be 6 mm broad. Don't make it broader. I really recommend to measure the incision length, 6 mm. The next step is to take a 15 degrees knife. Six millimeter broad, and then continue with a bevel up crescent knife and dissect a scleral flap. Don't dissect too deep, otherwise you will get an iris prolapse. Not too high, otherwise you will make a defect in the sclera. If the knife shines through the sclera, you are at the right level, just like this. Perform a nice scleral flap. Don't open the chamber yet. Continue with paracentesis at 9 o'clock and 3 o'clock. These two are needed for the iris claws. Inject viscoelastics to inflate the interior chamber. Then luxate the IOL a little bit up in order to be able to grasp it. This maneuver is always easier from pars plana. The next step is the opening of the interior chamber with a 2.4 millimeter blade. Some more viscoelastics. In order to stabilize the interior chamber. Then take a serrated jaws forceps, grab the haptic and extract the IOL in toto. With the capsular bag, the next step is an anterior vitrctomy from pars plana. You do not need a biome. Perform an anterior vitrctomy and observe that the tip of the vitreous cutter goes along the edge of the pupil. Some disturbing air bubbles from the diffusion line. Then take the iris spatula and check if there are some vitreous strands. I'm continuing now with the biome. This step is not necessary. I'm performing a little bit co-vitrctomy. But as you can see, there's no cortex left. And if you do not have a biome, don't worry, the step is not necessary. The next step, which is necessary, is the injection of acetylcholine or myocol to constrict the pupil. The pupil must be constricted before you implant an iris claw IOL. Do not implant an IOL on a large pupil. Here comes the IOL. The IOL is inserted upside down. Upside down. If you insert it behind the pupil, you see it fits nicely through the incision, which is 6 mm broad. A broader incision is a risk for a choroidal detachment. The next step is the centration of the IOL. The iris claws must be located at 3 and 9 o'clock. Check with the iris spatula that the paracentesis is open. Grasp the IOL with the IOL forceps. Flip the IOL behind the iris. You see that the patient moves. Now change the hands on the forceps. The patient moves again. Not the best moment. And do the same movement on the nasal side. Enclavate the iris tissue into the claws and release the forceps. The next step is the suturing of the sclera incision, I always perform a cross stitch. The incision is of course the dangerous part of this surgery. If the incision is too broad and you have fluctuations of intraocular pressure, you might get a choroidal detachment. I therefore always suture this incision. Don't pull the suture tight. You might induce astigmatism. The next step is the suturing of the conjunctiva. Then finally the removal of the trocars. You can see that this operation can be completely performed without biome. And the surgical time is very fast with maximally 30 minutes. It's important to work atraumatic so that you have no inflammation in the tear chamber. And no cellular deposits on the IOL. This does not happen if you work atraumatic. Thank you very much.